Hello everyone. In this lecture, we'll discuss about neonatal jaundice under the following headings. First, we'll brush through some common definitions related to NNJ, following which we'll learn about the pathophysiology and etiology of NNJ, followed by clinical features of acute bilirubin encephalopathy, how to score it, and what is chronic bilirubin encephalopathy or Kernicterus. Management will be dealt with in another lecture. Coming to definitions, you should know when not to treat jaundice. Physiological jaundice, it happens in newborns due to their inherent transitional physiology. They make a lot of bilirubin and have developmentally immature system to handle it. Then how does a fetus handle it? In utero, the entire bilirubin which is being produced, it is handled on the other side of placenta into the maternal liver. Once umbilical cord is cut off, the entire burden of managing this bilirubin, now it falls upon the newborn. If you notice, the activity of the key enzyme which is required in bilirubin metabolism, this enzyme is UGT1A1 or UGP glucuronide transferase. This enzyme's activity is developmentally regulated such that a child who is less than 30 weeks, a preterm child, will have only 0.1% of adult expression of this enzyme, and even by 40 weeks of gestation, the enzyme activity only increases to 1%. So even a 40-weeker has low activity compared to an adult. And to exacerbate this, the lifespan of RBCs is also very short, which adds on to the bilirubin burden. The third factor, which tilts the balance in favor of hyperbilirubinemia, it is the increased enterohepatic circulation. So whatever bilirubin is being produced and conjugated by the liver, it reaches intestine for elimination. But instead of getting eliminated, if at all it gets reabsorbed into the circulation on its way to the liver, this phenomenon is called enterohepatic circulation, and this phenomena is exacerbated in a newborn because newborns have immature intestinal flora. A mature flora, it favors elimination of conjugated bilirubin, while an immature flora, it favors reabsorption and recirculation, which is enterohepatic circulation. So all in all, we have three major factors. First is increased bilirubin production, an immature system to handle it because UGT1A1 is developmentally regulated, and number 3 is exacerbated enterohepatic circulation. Coming to pathologic jaundice, beyond the physiological range, any jaundice requires further investigation and treatment, and it is defined as being pathologic. How to pick up a pathological jaundice? It can present within the first 24 hours of life. And even though the clinical judgment is not considered reliable now, arbitrarily yellowing of arms and legs on day 2 of life, or that of palms and soles at any given age is also considered pathologic. Then a total serum bilirubin more than 95th percentile on age-specific normograms, or a rate of rise of total serum bilirubin more than 0.3 units per hour on day 1, or more than 0.2 units per hour following day 1, or more than 5 units per day following day 1 is also considered as pathologic. Then any level of bilirubin, total serum bilirubin, be it a low level also, but with definite features of bilirubin-induced neurological dysfunction, is also considered as pathologic. We'll read about these features in the coming slides. Lastly, a prolonged jaundice more than 2 weeks in term children and more than 3 weeks in preterms is also considered as pathologic. The next terminology is acute bilirubin encephalopathy or ABE. All the neurologic signs and symptoms which happen in acute setting due to hyperbilirubinemia, they are known as acute bilirubin encephalopathy. And if they are severe or not managed well in time, they lead to a permanent sequelae called chronic bilirubin encephalopathy, also known as Kernicterus. So Kernicterus is a permanent clinical sequelae of bilirubin toxicity, and it is characterized by some or all of the following features. So these features are there. We'll discuss about these along with characteristic MRI changes in brain, which also we'll be dealing with in the coming slides. To expand our understanding, let's first delve into bilirubin metabolism. Bilirubin is a degradation product of heme, which is mainly sourced from the hemoglobin of red cells, but there's a minor contribution from other heme proteins as well. This heme is acted upon by heme oxygenase to produce an equimolar amount of carbon monoxide and biliverdin. Biliverdin converts into bilirubin when it is acted upon by biliverdin reductase, And this bilirubin which is formed is called as free bilirubin, and it is available to the brain because of neonates' immature blood-brain barrier. But in healthy neonates, this does not happen. This does not happen because bilirubin in bloodstream is found attached to albumin. And albumin prevents bilirubin from entering the brain and therefore preventing neurotoxicity due to it. And on that note, we can expect that any cause which is causing hypoalbuminemia, be it prematurity, sepsis. Since sepsis, albumin is a negative phase reactant, so sepsis will cause hypoalbuminemia, liver dysfunction, and maybe the neonate is NBM and isn't getting supplemental parenteral nutrition adequately, or just because of any cause the nutrition is inadequate, or maybe the neonate is receiving certain drugs like sulfa drugs, or even a rapid infusion of ampicillin. What they do is they displace bilirubin from albumin and therefore causing a hypoalbuminemia like condition. So whenever there is low albumin, the amount of free bilirubin will increase and it therefore predisposes to neurotoxicity. On the same note, it is also worthwhile to note that a ratio of bilirubin by albumin, it is a surrogate marker of free bilirubin. Whenever it is more than 7, it predicts a worse outcome and a severe condition. Coming back to the metabolism, bilirubin which is bound to albumin, it enters into the liver and is ultimately conjugated using UGT1A1. This conjugated bilirubin, it gets excreted into the intestine via bile. Now, if at all there is enough and more good bacteria, this conjugated bilirubin will undergo bacterial decomposition and be excreted via stools as stercobilinogen and via urine as urobilinogen. If at all there is not enough and more good bacteria, for example in preemies or in early neonates, more and more conjugated bilirubin will get deconjugated because of the action of beta-glucuronidase which is present in intestine, and this unconjugated bilirubin will get absorbed into the circulation on its way back to liver to enhance the hepatic bilirubin load, and this is called enterohepatic circulation. And therefore, to summarize, we can broadly classify the causes of neonatal hyperbilirubinemia into two main categories. Number 1 is increased bilirubin load. Number 2 is decreased hepatic bilirubin clearance. When we talk about increased bilirubin load, we are essentially talking about a lot of hemolytic disorders and a few other conditions like cephalhematoma, polycythemia, and also enhanced enterohepatic bilirubin circulation. This particular cause, it enhances the bilirubin load to liver and it also impairs the excretion of bilirubin in the form of stercobilinogen and urobilinogen, and therefore is included in both the categories. First, we'll discuss the hemolytic causes. In hemolytic causes, hemolysis can be because of immune-mediated causes. So, immune-mediated hemolysis. In this, the antigen can be Rh, A, B, whenever the mother is O positive, or other minor incompatible antigens can be present on the neonate's RBCs. When we take this baby's red cells and act them upon with anti-human antibodies, these antibodies, they catch hold of them and they agglutinate the red cells, giving a positive direct Coombs test or direct agglutination test. Next, we can have membranopathies. In membranopathies, we have hereditary spherocytosis, elliptocytosis, pycnocytosis, or stomatocytosis. Whenever we look at a peripheral smear of a newborn, even physiologically, one can find a lot of different shapes of red cells due to their transitional physiology. But spherocytes are always atypical and they point to a diagnosis of hereditary spherocytosis. And so does a increased MCHC or mean corpuscular hemoglobin concentration of more than 36.5. It indicates that there could be hereditary spherocytosis. Then we have pycnocytosis. Now this pycnocytosis, it is essentially a transient phenomena. When we look at a preterm, 5% of preterm's red cells in a peripheral smear, they will be pycnocytes. However, if they amount to 50% of the cells in peripheral smear, it can be a matter of concern, so much so that the child might require exchange transfusion. But as I said, it's a transient phenomenon and it just resolves in a couple of months after birth, until which the child does need therapy. After membranopathy, we have enzymopathies. And in enzymopathies, we'll mainly discuss about G6PD deficiency in coming slides. So as yet, we have seen immune-mediated. After that, we have seen membranopathies, enzymopathies, and now we'll look at hemoglobinopathies. When we had discussed about membranopathies, there's a test called osmotic fragility test which is carried out because of the reduced surface area, because in membranopathies the membrane surface keeps getting torn off and the cells take a spherical shape. Now, because of this reduced surface area which this cell attains, whenever RBCs are exposed to increasing dilutions of saline, these RBCs, they tend to burst at lower dilution. Say, even at 0.7% of dilution, this RBC will tend to burst because it can't accommodate any fluid inside it as the surface area is decreased. In case of hemoglobinopathies, as hemoglobin reduces, the surface area within the RBCs, it increases. And when we expose these red cells to increasing dilutions, we notice that these red cells, they do not burst. They keep on accommodating more and more fluid. And even at higher dilutions like 0.3%, these RBCs, they won't burst. And this test is known as Nestrov, which is naked eye single tube red cell osmotic fragility test. And because the neonates, they don't have beta hemoglobin, they'll manifest only alpha or gamma thalassemia at this very age. Now, coming to the other causes, that is decreased hepatic bilirubin clearance. We have prematurity. As I've already discussed, in premature infants, there is decreased activity of UGT1A1. Then premature infants, they tend to be having inotropic support, because of which sometimes the nutrition is also withheld, right? Enteral nutrition is withheld, which enhances the enterohepatic circulation. Again, if intestinal flora is not well developed, which again contributes to increased enterohepatic circulation. There are many, many more causes, but premature infants, they basically have a decreased hepatic bilirubin clearance because of all these causes. Then hypothyroidism and hypopituitarism, a decreased level of thyroxine or a decreased level of growth hormone, all of that, it impairs the activity of UGT1A1. It can cause cholestasis, intestinal hypomobility, and delayed passage of meconium, again decreasing the clearance of bilirubin. After this, we have patent ductus venosus. What happens is, in case of a patent ductus venosus, the portal blood, it bypasses the hepatic circulation, it enters the systemic vena cava or IVC, and therefore bilirubin is not metabolized within liver. There's a portosystemic shunt which is created because of the patent ductus venosus. Lastly, we have UGT1A1 variants, also known as inborn expression of UGT1A1 or indirect hyperbilirubinemia syndromes, which comprise of 3 types. Based on severity, Crigler-Najjar type 1 has the most severe type of hyperbilirubinemia. Crigler-Najjar type 2, also known as area syndrome, it has moderate amount of hyperbilirubinemia. And then we have Gilbert syndrome, which only has mild hyperbilirubinemia. Type 1, if we look at it, the UGT-A1A activity is completely absent, not detected at all. Therefore, these kids, they'll end up with hazardous hyperbilirubinemia, which is more than 30 mg per dl of total serum bilirubin. And all of them will end up with bilirubin-induced neurological dysfunction, a severe variety, if not managed well in time. And the only definite treatment here is a liver transplant. Or other than this, these days, human hepatocyte transplant is being tried, or maybe an effective gene therapy. As and when it develops, it will be very helpful in this particular syndrome. Type 2, also known as area syndrome, over here the activity of UGT1A1 is low, but it is detectable and it is inducible also with phenobiopsy. Hyperbilirubinemia is in moderate level. Then Gilbert, it is far, far more common and a lot more milder in intensity. So much so that it seldom requires any therapy if it is alone it is present. It is more relevant when it is associated with other conditions which are predisposing to hyperbilirubinemia. What happens is they have a extra base pair in the Tata promoter sequence of this enzyme gene, the UGT1A1. And which basically decreases the activity of UGT1A1. However, in Asian variants, there is a single nucleotide polymorphism wherein glycine is replaced by arginine, and this causes the activity to decrease a little bit. Now, having understood this, let's now focus on G6PD deficiency. We know that G6PD deficiency, it is an X-linked disorder, and therefore it will affect hemizygous males, or it will affect homozygous females, or it will affect heterozygous females with X1X inactivation. Suppose the sex was normal and it got inactivated, so they'll also be affected. We all know that G6PD it protects the red cells from oxidative damage. In neonates, sepsis, necrotizing enterocolitis, or certain drugs, including vitamin K as well, they can cause oxidative stress. And absence of a functional G6PD will lead to hemolysis and hyperbilirubinemia associated with anemia in these kids. Now that we know all the causes of hyperbilirubinemia, let's see how the neurotoxicity presents. We had read that all the acute neurological signs and symptoms due to hyperbilirubinemia, they are referred to as acute bilirubin encephalopathy. And from all we have read, we can conclude that neurotoxicity risk factors in a child can be prematurity, gestational age of less than 38 weeks, then hypoalbuminemia, as we have already seen, then various autoimmune and hemolytic anemias or other basically type of hemolytic conditions, then sepsis, and another point which has been added by AAP 2022 guidelines is that a significant clinical instability in previous 24 hours, it is also a neurotoxicity risk factor. Then in sepsis, we have read that sepsis leads to hypoalbuminemia and that can lead to neurotoxicity. Also, I want to mention one point here that whenever sepsis happens, there is upregulation of heme oxygenase 1 and 2 in brain. So what happens is brain produces its own bilirubin by consuming the heme which is present in brain. So even though the peripheral blood bilirubin might be low, but because of sepsis, the child might be producing a lot of bilirubin within the brain, which is causing direct toxicity within the brain or mind is. Since encephalopathy in a newborn, it is a little difficult to gauge objectively. Therefore, we have a scoring system also known as bind score or bilirubin-induced neurological dysfunction score, wherein we study the neurodysfunction or neurological dysfunction based on mentation, muscle tone, or cry pattern. Mentation, muscle tone, or cry pattern. You can remember this either as MMC or Madras Medical College, or you can remember it as MTC or Malnutrition Treatment Center. I know it looks like a really busy slide, but this scoring system will be more dynamic after we've seen a few kids with ABE. So let's just watch a few videos. Later we'll come back to this particular slide.
This was at admission of case 1. As you can see, this baby was deeply icteric palms and soles, and baby was having stereotypic.
As you saw in this video, the child looks a little irritable and cry was shrill and the child seems a little difficult to console. Then talking about tone, there is a definite retrocollis or arching of the neck at this moment, along with arching of back, which is also known as opisthotonous posturing. And we can also notice bicycling and paddling type of stereotypic movements. So overall, this child will be given a score of 7, which indicates a severe acute bilirubin encephalopathy.
So this was the condition of baby at admission. This was a video taken in emergency. So baby was not undressed. We can see that baby was lethargic. There was retrocollis. On stimulus, there was increase in tone.
The second neonate seems sort of in a semi-comatose state. You can notice there is beginning of retrocollis or arching of neck and the cry is very, very weak. This child gets a score of 8. Now let's come back to the scoring system. If everything is normal, then a score of 0 is given, which is the best score possible. Now coming to mentation, when there is very mild affection because of bilirubin, the mother will tell that the child is mostly sleepy. But upon arousing, the child gets up and is active also and does drink milk. But overall, because of excessive sleepiness, the child's intake of milk has decreased. With time, as the encephalopathy worsens, the child will go on to being lethargic, will have predominantly a poor suck, with alternating periods when the child is irritable, jittery, and intermittently the child is also having a little bit of strong sucking. Lastly, ultimately, the child will land up in a semi-comatose state. The child will have apnea. This is important as apnea in a term child, it has a very few differential diagnoses. It is a sepsis mimic, and secondly, it can be a encephalopathy pattern. Then the child is unable to feed, or the child is in a comatose state, throws a lot of seizures. Then coming to muscle tone, if everything is normal, the tone is also normal. In mild affection, there will be a persistent mild to moderate hypotonia. When severity increases, there will be intermittent episodes of hypertonia. beginning of arching of neck and trunk, and ultimately there will be a persistent retrocollis, opisthotonus, and stereotypic bicycling and paddling movements will be there. Crying pattern, initially there will be the child will cry very loudly when aroused by mother, followed by a shrill cry, and the child is very difficult to console, and ultimately the child will have an inconsolable crying, or the cry will be completely absent or very weak, with a history that initially the child was having a very shrill cry and was very difficult to console. So this is about bind scoring pattern. A score of 1, 2, 3 is mild, 4, 5, 6 is moderate, and 7 and above it is severe. This score has now been modified, and there's a fourth component which has been added, which is called as oculomotor movements, wherein if there are normal oculomotor movements, the score given is 0, or if the child is having up gaze palsy or sun setting sign, a score of +3 is given. The severity scoring remains the same. This is known as M-bind or modified bind score.
This was the condition post DVAT and phototherapy of 1 to 2 days. So we can see that baby is still having poor feeding. Baby was being fed through OG tube. There was retrocollis, and baby was having stereotypic movements, and still irritable. Baby was still irritable, and this was a discharge. And gradually baby has improved, but still there was stereotypic movements, and there was Kernicterus faces we can observe. There was anxious look, and also baby was having late retraction suggestive of Kernicterus faces. This might be having sequelae in the future.
Whenever acute bilirubin encephalopathy is not managed well in time, or it was very severe to begin with, these kids usually land up with a permanent sequel, which is also known as Kernicterus. In acute settings, typically there will be symmetrical T1 hyperintensities in globus pallidus. Since bilirubin, it tends to affect the extrapyramidal pathway specifically, so basal ganglion, subthalamic nuclei, hippocampus, cerebellum, all these are commonly affected. Here again in case 2, you can see that there are bilateral symmetrical T1 hyperintensities in bilateral global pallidi, subthalamic nucleus, and there are mild T2 hyperintensities as well. Significant T2 hyperintensity will be seen in a chronic pattern or Kernicterus. It is characterized by T2 hyperintensities in the bilateral and symmetric increase of T2 or flare signal in globus pallidus and subthalamic nucleus. As you can see, there is evolution of T2 hyperintensity. With time, it is getting whiter. So this is a case of Kernicterus evolving. To wrap up, chronic bilirubin encephalopathy or Kernicterus is a permanent sequel of bilirubin toxicity, and it can have some or all of the following features. There can be movement disorders, and these as the extrapyramidal tract is involved, the movement disorders will also be extrapyramidal, like dystonia, dyskinesia, chorioathetosis, etc. Let's look at a few cases.
Video, this child is having this flowing moments or dancing moments. He's keeping on dancing. He's not steady. He's keeping on writhing the fingers. So there is some athetosis. He's like jerking, okay, and his like trunk is like almost like twisting again and again. So what is the definition of chorea? Chorea is sudden, random, arrhythmic flowing movements. Okay, arrhythmic flowing movements. So the two keywords are, it's not rhythmic because a tremor is a rhythmic. Okay, it's a arrhythmic flowing movements. So if you see this site of chorea, you should always try to know that this is probably because of a basal ganglia damage, gives a clue regarding a dyskinetic cerebral palsy. And if you see like this sort of a arching posture, twisting posture, see the child of the hand, it is like twisted backwards. Okay, so the key word is here is twisted. It is not only stiff, but it's also twisted. Okay, neck twisting, okay, hand twisting, leg twisting. It's again a clue for a dyskinetic cerebral palsy, or this is known as dystonia. So in this video, again, you can see how much this child is having, the hands are kept like this. See the way his necks are twisted and contoured. Okay, there is like arrhythmic, sometimes sustained, sometimes intermittent twisting postures. Okay, so dystonia is not only stiffness, but in addition to stiffness, there is a lot of twisting. So this is a child with a bilirubin-induced brain injury.
Having understood the movement disorders, let's look at the other features. There is auditory neuropathy. In auditory neuropathy, it is a type of sensory neural hearing loss wherein the outer hair cells, they are basically spared. The affection happens either at the level of inner hair cells or the anastomosis between the inner hair cells and the afferent fibers of cochlear nerve or the cochlear nerve itself. And therefore, it is essential to consider all of these kids who are AB NICU graduates as high risk kids. And in them, the hearing screening will be done by both OAE as well as AABR, and not just OAE because these are high risk kids. The third feature is enamel dysplasia. And then lastly, we have an upgaze paralysis. In upgaze paralysis, whenever the child is asked to look downwards, the downgaze is preserved. But upgaze, when the child is asked to look upwards, the child instead tends to extend the neck upwards. That is all about hyperbilirubinemia and its neurotoxicity. I have included links to the videos that I have used in the lecture. Do go through those videos as well. We'll read about management in the next lecture. And please don't forget to share this lecture with all of your friends. Thank you.